Hi everyone, here we are again with another tutorial for X-ray workers. In this video, we will talk about the lumbar spine X-ray procedures and technique, and I'm sure by the end of this video, you will learn something new and would be able to perform lumbar X-rays in the most proper way. But before we start, let's have a quick look on the indications of lumbar X-rays, as these may help you to decide which technique is the best for each specific patient. Well, there are a variety of medical conditions in which lumbar X-rays are performed, including fall from a height, ejection from a motor vehicle or a motorcycle, or even a bicycle, acute back pain, neurological defects, and also postoperative patients, and in most cases, chronic conditions like lower back pain, which may radiate to lower limbs as well, and in patients suffering from cancer, like bone cancer, the one we call multiple myeloma. So the physician is looking for metastasis in the body of the vertebrae. So the lumbar spine series is comprised of two standard projections along with a range of additional projections depending on clinical indications. So the two standard projections are the anterior view, known as a PA or AP, and the lateral view. And the other additional projections including oblique views, dynamic views, which include flexion and extension. It highly depends on the patient medical background and the clinical indications. But in this video, we only covered the anterior view and the lateral view. And for sure, we will talk about the other additional projections in the next videos. And as always, I want to talk about the patient preparation. First and foremost, take a brief history of your patient. Most radiographers will skip this step. However, it's important to know the patient medical background and chief complaints. This will help you to implement the best technique and protocol, and consequently helps the physician to have a proper diagnosis. And also check the pregnancy condition in case you have a female patient. Explain the procedure for the patient. Remember, do not just go through the procedure mechanically. As a healthcare professional, you need to communicate with your patient. So, number one, take history. Number two, explain the procedure. Asking question, giving information. These are the two main parts of the patient communication. So, the routine procedure for the lumbar X-ray is to remove all opaque objects from the area and to ask the patient to wear a hospital gown. And don't forget, the radiation protection depends on the procedure you're going to perform. Try to have protection on the sensitive organs. So in this case, we're going to do a lumbar X-ray, and you can do protection of the thyroid, which is very sensitive to radiation. And you can also put shield on the gonad area, but it highly depends on the medical condition of the patient. If you're going to include the sacrum and the coccyx in your radiograph, so for sure, you cannot put gonadal shield because they will overlap the coccyx and the sacrum area. But in case that the physician is only wants the lumbar vertebrae and it's not necessary to include the sacrum, you can put gonad shield, especially in young patients. So it highly depends on the clinical condition and the reason of the X-ray. But in case you have an acute case, you have a trauma case, for sure you need to include the sacrum and the coccyx because of the suspected fracture. So you cannot put gonad shield for this kind of patients. Okay, so let's move on to the technique and the protocol. Basically, lumbar X-ray can be performed either in erect or supine position. However, remember, spinal alignment is usually assessed in a standing radiograph. So normally you have to do the X-ray in the upright position, not in the supine position. The many disadvantage of supine position, that we will cover in this video. We're going to talk about them, but only in cases that the patient is not able to stand, whether the patient is a trauma patient, there is a suspected of a spinal injury or a fracture, or any other reason, any medical condition, the patient is aged or unable to stand, you are allowed to do the X-ray in the supine. Otherwise, as a rule of thumb, you have to do the lumbar X-ray in the upright position, okay? So anterior projection upright can be done in both AP and PA view. Almost all the radiographers will do the AP projection, but there are some advantages of the PA method, like reduce dose to the gonadal region and less beam divergence. So it's better to do the PA projections of the lumbar X-ray. Only in cases that the patient is obese and he or she has a big stomach, so that will cause the distance between the image receptor and the lumbar spine to be increased. Actually, the OID will be increased. So in these cases, better to do the AP view. But alternatively, for a normal patient which is not obese, it's better to do the PA view. Regarding the patient procedure in PA or AP erect projection, you need to ask the patient to stand upright with the arms at the side, align the mid-sagittal plane to CR and the midline of the table, and ensure there is no rotation of thorax or pelvis. And always check the patient that he or she is not leaning back to table. So he or she should be completely in the upright, natural position. The center point should be at the iliac crest at the mid-sagittal plane. So the iliac crest is our central ray, which is the easiest landmark of the body. You can easily touch this area, and it's easily palpable even in the obese patients. And the central ray should be perpendicular to the image receptor. Collimation is of great importance. We will discuss about the collimation in the next slides. So from the superior, you should have the T12 and L1 junction in your X-ray, in your image. And from the inferior, you have to include the sacral region. Lateral to include only the transfer process and the sacroiliac joints. So do not open your collimations widely. You just need to include the transfer processes and the sacroiliac joints. So normally these days, everyone are using the digital machines with the image receptor inside the table. But in case you're still using the cassette, you have to choose the vertical 35 to 43 cassette. The exposure is highly depends on the patient's body habitus, whether the patient is thin or is obese. But in a normal adult patient, you have to implement these factors: kilo voltage of 70 to 80 and milliamp per second of 40 to 60. And again, mostly in the new X-ray machines, it's automated exposure factor, so the system will choose the best exposure factors for the best image quality. The SID, which again we will talk about in the next slides, should be long enough, 150 to 180 centimeter. So as a rule of thumb, when you're doing X-ray of the large organs or a large area of the body, you have to choose approximately long SID. And of course, you need bulky and grid lines to have a good image quality. And in cases that the patient is unable to stand, you have to do the AP projection in the supine position. It's almost the same technique as the erect and upright position. The only difference is that you have to flex the patient hips and knees to ensure the back is flat. So normally when the patient is lying down on the table with the straight legs, there is a false curve, there is a bending in the lower back. And to resolve this bending, you have to flex the knee and the hips to ensure the back is flat. Okay, this is a very important tips in the AP supine position. And of course, for the patient comfort, you can put a pad or a pillow underneath the knees. So here is a normal proper projection of the lumbar spine. So as we mentioned, from the superior, you need to include at least T12 to L1 junction. So this is L1, this is T12, L1, L2, L3, L4, L5, and the two sacroiliac joints from the lateral. And as we go further, this is the coccyx area. So if the request is lumbosacral spine, you need to include the whole sacrum and the inferior part of coccyx. But in case it's only the lumbar spine, maybe till this area is enough. You don't need to include the coccyx. And also you can put shields for the gonads to have more protection. So intervertebral joints are visualized. So this is the intervertebral spaces, can be clearly seen. Adequate image penetration and image contrast is evident by clear visualization of lumbar vertebral bodies, pedicles, and facet joints with both trabecular and cortical bone demonstrated. So you can clearly see the bodies, the pedicles, and also the transverse process. But sometimes the bowel gas and fecal material may overlap the transfer process. But anyway, in the AP projections, we're not going to evaluate the transfer process. They mostly be evaluated in the lateral projection. Okay, no patient rotation as evidenced by central spinous processes and the symmetric appearance of the sacroiliac joints and iliac wings. So if you want to evaluate that the patient has no rotation, this is the spinous processes should be in a midline. But of course, in normal patients, if the patient have a scoliosis or other spinal deformities, you may not see these spinous processes like here. And the other alternative thing you can check is the sacroiliac joints, which I mentioned here, and here should be equal distance from the midline of the spine. And also you can check the iliac wings as well for the rotation. Okay, let's move on to the next slides. And we're going to talk about the lateral projection. Again, we have two options, erect and recumbent. And same as the anterior projection, the erect projection is advantages of recumbent position. So normally, you have to do the lateral position, same as the AP projection in the upright position. When you ask the patient to lie on the side, on the table, there is a false curve in the spine. Normally, there's curve here. There are methods that I'm going to mention to correct this positioning, to remove this curve, and to make the whole spine straight. But to be on the safe side, try to do the lateral position, again in the upright position. The only disadvantage of upright is a motion artifacts, because the patient is standing without any support or any place to lean, so the chance of motion artifact will be increased. There is also a slight decrease in the image quality due to the distance between the pod and the image receptor. So make sure if you're doing the lateral position in the upright, make sure the patient is as close as possible to the image receptor. So regarding the positioning, the patient is positioned erect, supine, or lateral, lateral recumbent, depending on clinical history. In the lateral decubitus position, position the patient so that the arms are extended 90 degrees to the thorax with the elbows flexed so that the forearms are parallel to the thorax. In the erect position, ask the patient to cross their arms over their upper thorax. I normally ask the patient to cross their arms and to hold the shoulder. Okay, in the lateral projection, to minimize the superimposition of the diaphragm and the lungs on the lumbar vertebrae, you need to instruct the patient of the breathing technique. You need to take the exposure at the end of expiration. So you need to instruct the patient to breathe out and to hold his or her breath. The center point again is at the level of the iliac crest. The exposure factor, same kilovoltage as in the anterior projection, but an increase in the milliamp per second due to increase in the thickness of the parts. SID again, a long SID of 150 to 180 centimeter, and of course we again using the Bucky and the grid line to have a better image quality. So again, in case you doing the projection, make sure you're putting the proper support on the head and also underneath the waist. You need to position the patient in a way that the spine is as straight as possible, not like the left picture, okay? So it's highly dependent also on the patient body habitus. And by that, I mean the different width of the patient's shoulders, the waist, and of course, the pelvis area. So mostly all the patients has wider pelvis than their waist, especially in the female patients, almost all of them. And this will cause a curve in the lumbar area. And when you're doing the lateral projection, so the rays are perpendicular to the image receptor. In this way, the body of the vertebrae are curved, so the X-ray beam will not pass directly between the intervertebral joints. So you don't have a proper lateral X-ray. To resolve this issue, I personally suggest to have a 5-degree angle of the central ray. This will give you the best result in case you do the lateral while the patient lying on the table. So here's a case, a female patient I've done a couple of days back. So you can see the true lateral and the 5-degree caudal lateral. You can see the difference in the intervertebral spaces. You can see this right here and here, and also this is all because the patient spine is not straight while lying down on the table. So the 5 degree angulation will do the job. See how open is the intervertebral spaces and how the different parts of the body of the vertebrae are visualized in the image. SID also is of great importance in lumbar X-ray studies. As I mentioned earlier, you have to have a SID of 150 to 180 centimeter, a long SID. So here's an example of a short SID, I think 100 to 110 centimeter. You can see that in the center of the image, the intervertebral spaces are clearly visualized, but as you go further from the center, you can see how they overlap each other. And the reason behind it is when you implement a short SID, the beam divergence is far more when you have a long SID. So the beams are going with a more angle in between the disc spaces. But if you have a long SID, the beam divergence is far less. So almost all of the beams go exactly perpendicular to the disc spaces. And finally, the collimation, which highly affect on your image quality and to signal and noise ratio. So here's an example. Same patient, same time, but on the left side you see a very, very open collimation, and this one is a limited collimation. You can see on the left side how noisy is the image, and on the right side you have a clear, perfect radiograph. So remember to limit your collimation to the region of interest, to reduce noise, and also to reduce radiation backscatter and consequently radiation dose to the patient. Alright, that's it. Thanks for watching my video. I hope you learned something from this tutorial. Please do subscribe my channel to support me and check out my other radiology videos from the playlist in the channel. Thanks again. Have a good day.